I want to ask you gentlemen a question. I'm Larry Perlman. I'm a clinical psychologist. I'm in private practice.
Put the mic near your mouth.
I'm Larry Perlman, clinical psychologist. I'm in private practice in Ann Arbor, and I was formerly at the VA hospital and on the faculty at the University of Michigan in the Department of Psychiatry. Question came up at lunch. There are, in the private practice community, it is virtually impossible to find somebody, a psychiatrist who takes insurance reimbursements, who's on the panels. And this has been a source of frustration for those of us who want to refer and collaborate with a psychiatrist. Do you have an answer to this? I know Blue Cross is concerned about it because I'm on the insurance committee of the State Psychological Association. But I'm just wondering if this is something that's discussed in the societies or within the universities. And there was a young psychiatrist who finished a residency program a year ago and started a practice and took insurance reimbursements, and within 4 months he stopped doing it. It was too much of a hassle for him, too much extra administrative work. So you guys have a response to that. Thank you.
All right, well, I'll start, and again, I think I got the microphone in the right place, but if it's not right, let me know. You have asked the perfectly wrong guy. I was on the faculty of the University of Michigan my whole career, and billing and insurance were somebody else's problem. They paid me a salary and kept all the rest. I can't really answer for private practice. I think one thing that happens is that it's not just that they do or don't take insurance, but you can fill up your practice and then you just don't take anybody. Well, you slowly take people as people leave your practice. But one of the problems is that people soon after residency, if they're good and or lucky, will fill their hours, and I think that's part of the problem.
Right, I concur with Dr. Cameron. So I too have never been in private practice. Was at the university for a while, and now kind of in the public sector with our community mental health system, which focuses on serving people who have Medicaid or who do not have health insurance. But it does feel like a problem to me because one of the other things I do is work with primary care doctors in a safety net clinic, a clinic that serves people who are uninsured or underinsured. And it is difficult to find private psychiatrists for people who are new to insurance. At least this is what we are discovering these days. With Medicaid expansion, the Healthy Michigan Plan, fantastic thing that people have health insurance. And there is a mental health and substance abuse treatment benefit with Healthy Michigan, which is fantastic. And all of the managed care providers for those Medicaid insurance plans do have people on panel, if you kind of look at the lists that we see, that we try to refer people to. But that doesn't mean it's easy to get in. Yes, the phrase phantom panel has come up multiple times. And what I'm hearing from some of my colleagues is that sometimes there's a 3-month wait or a 6-month wait, or, oh no, the list wasn't quite right. And I know at this point we have some people who are kind of coming off of hospitalizations for mental health reasons who are going to primary care docs, actually, because it's sometimes difficult to find a psychiatrist in the community. What is the answer to this conundrum? I'm not sure, but I think it's the right question. And I know the Michigan Psychiatric Society has identified that as an issue.
Yeah, I guess I would make a couple of additional observations. First of all, as much of a problem as it undoubtedly is for you, it's far worse if you go way outstate. One of the issues, I'm involved with a number of boards that do advocacy and so on, and there's a lot of talk and a lot of disagreement about, well, should we give psychologists more prescribing privileges? Should we allow nurses a more free practice to be on their own? And there's a whole list of those kinds of things that come up. And part of me, and don't quote me, although the room's full of people who can quote me, you know, I'm not supposed to think that those folks should be allowed to have more practice and so on. But if you're realistic, you look at that and you say, wait a minute, you know, we've got to figure out a way to deliver services to an adequate number of people. So, you know, on my little left shoulder, the angel's saying, oh, let them do more. You know, we should oversee them, but let them do more. So, but on my right shoulder, if you look at the map of the distribution of people of all stripes who are doing mental health, they're all in the same place. So if tomorrow we said, all right, we'll let all those people who want to prescribe certain kinds of psychotropic medicines prescribe them, there would still be a massive shortage in the Upper Peninsula. There would still be a massive shortage in Gaylord, et cetera, et cetera. So it's not clear that that's really a solution. And I say this in part because, you know, I look around the room and I know, at least in the seminar session we had just before lunch, there was a number of students in there. You know, not everybody practices in Washtenaw County or in Oakland County. And as much of a problem as it is, it's even harder the farther you get away from the academic and the urban centers.
Yeah. Telepsychiatry has taken off. So there are opportunities for more rural areas to contract with behavioral health providers from places where there is a high density of them, and actually have an opportunity to, I believe, do some billing now. So that is at least one push in the right direction for those folks.